My presentation is on the assessment and intervention of amyotrophic lateral sclerosis, or ALS, or commonly known as Lou Gehrig's disease. Amyotrophic translates to no muscle nourishment, which could then lead to atrophy of the muscle. There is no known etiology or cure for ALS, and it is very rare and it attacks motor neurons, meaning the person may lose the ability to speak, eat, move, and breathe. The symptoms vary from person to person, as different muscle groups may be targeted, and the progression of the disease may vary in speed. Common symptoms include progressive muscle weakness and paralysis, which can be shown by tripping, dropping things, abnormal fatigue, slurred speech, muscle cramps, or uncontrollable periods of laughing or crying. The condition has a gradual onset, but again varies in its pace. The average survival time is 3 to 5 years, and the cause of death is usually respiratory failure, pneumonia, or cardiac arrhythmias. It is usually diagnosed between the ages of 40 and 70, and I thought it was important to note that there are two types. There's sporadic, meaning it affects anyone, which holds 90 to 95% of the cases, and then there's familial, which is the remaining 5 to 10%. Also, I found it interesting that military veterans are twice as likely to be diagnosed with ALS, but we do not know why. The most commonly used assessment for this population is the ALS Functional Rating Scale, or the ALS-FRS. It is used to establish a baseline and then assess the progression of the disease over time. This is a simple questionnaire format and it addresses 4 domains: bulbar function, fine motor, gross motor, and respiratory insufficiency. It is very easy to use and it is available online, which I will show you in just a second, and it has good inter-rater reliability and validity. Okay, so I'm going to go ahead and show you guys the assessment. It's just a questionnaire that has different options for each category. So this website is really handy. I'm going to go through and give some random answers, but I'm just going to show you all the different categories and everything. So for speech, there's all these different answers from normal to loss of useful speech. Salivation, swallowing, handwriting, no, cutting food. Just gonna give a bunch of different answers here. Walking goes from normal to no purposeful leg movement. Climbing stairs. And then all the way down to respiratory insufficiency. So then, as you can see down here, it gives you the percentage of a 9-month survival rate. And then you go ahead and click next steps, and it takes you down here and it gives advice, management, and critical actions. And I just thought it was really nice. It was convenient to have. But yeah, it's really easy, doesn't take long to do. Some other simple assessments to consider would be ADL or IADL assessments, range of motion, manual muscle testing, and the Borg scale. The first intervention plan that I found to be common for this population was resistance exercise programs. The main thing to take away from the articles I found was that the programs cannot be generalized because of the varying stages and symptoms. Two people who are both in the early stages may have completely different levels of fatigue and weakness. If the muscle group tests less than a 3 on a manual muscle test, that muscle group should not be included in the program. One study used moderate load and moderate intensity exercise for the upper and lower extremities for 6 months, which resulted in significantly less of a decline in overall global function, especially in lower extremity muscle groups, which was measured by the ALS-FRS that we just talked about. And there was also a significantly less of a decline in quality of life over time, but there was no difference in levels of fatigue. Another study states that 6 isometric contractions held for 6 seconds each, along with sub-maximal elastic band exercises, could maintain and/or improve strength. Exercise programs will not help the patient regain muscle strength, that was lost due to the disease, but evidence shows that mild to moderate resistance exercise programs may help the client maintain strength of unaffected muscles, maintain functional independence for a longer period of time, and adding a personalized range of motion and stretching program to the client's routine will help prevent joint contractures, especially with clients who have spasticity. Overall, the evidence for resistance exercise programs is controversial and inconclusive. Exercise may not have any ultimate effects on disease progression and mortality, and although exercise may improve function, increase strength temporarily, and decrease the effects of disuse atrophy, an exercise program will not cure the condition. We already know so much about assistive devices and equipment, but with this population, it is critical that you are mindful of what you, as the OT, are giving the patient. Dependence on devices was regarded as a constant reminder of what patients had lost. One article I found really focused on the struggles that this population faces with the fast pace of the disease and the struggles of losing control. One article had a quote from a man who had been diagnosed with ALS. He said, "It turned me into an old man overnight because suddenly you're going with a walking stick and then you're with a rollator. Now you're in this wheelchair and it's just robbery of everything." Assistive devices are one way to allow the client to maintain their independence for as long as possible. They are effective in minimizing energy output and improving function with ADLs. Most common utensils used for cooking and self-care have a small grip diameter, meaning those with ALS may have a difficult time holding on to the tools if their hands have been targeted by the disease. This would then require more energy output to be used. Here, introducing adaptive equipment may be beneficial. Individuals diagnosed with ALS self-reported the following devices on their level of usefulness and satisfaction. Those that are used frequently with high level of usefulness and satisfaction include grab bars, raised toilet seats, shower seats, slip-on shoes, ankle braces, and transfer boards. Those used infrequently with high levels of satisfaction include sound or voice-activated environmental controls and communication boards. Those that were not found useful and had low levels of satisfaction include button hooks, dressing sticks, and long-handled reaching tools. When it comes to wheelchairs, a client may start with a companion wheelchair in the early stages of the disease. These are typically used for energy conservation during long-distance traveling that would tire the person out to walk. These are also lightweight chairs that are easy to transport to and from places, like in and out of a car. A manual chair could most likely be used by the client in the next stages of their disease, but due to the nature of ALS, clients will likely need to switch to a power wheelchair sooner or later. Jumping to a power wheelchair rather than a manual wheelchair will eliminate the cost of the manual wheelchair, and power wheelchairs have the ability to be adapted to fit the needs of the client throughout the course of the disease. Manual wheelchairs use too much energy to propel, and power wheelchairs have higher satisfaction rates due to more ease when participating in social events. Power wheelchairs allow for independence to be maintained as the client is able to propel the chair on their own by using a joystick, sip and puff, or other adaptations. This slide mentions some of the important features of a wheelchair. None of these features are new to us, but these considerations, on top of everything else we typically look at as OTs, are especially important with this population. Wheelchairs should have the ability to tilt and recline. Many individuals with ALS find that it becomes too difficult to transfer in and out of bed during the late stages of ALS, so they would rather sleep in their chair. Elevating leg rests will allow for reduction of edema, and armrests should be contoured and adjustable, especially when upper extremities are no longer functional. Common orthoses used with the ALS population are AFOs, wrist cock-up splints, and resting hand splints. AFOs help with the dorsiflexion during ambulation. Wrist cock-up splints allow for further wrist extension to obtain utensils, grooming aids, or other materials, and resting hand splints are effective in preventing wrist and hand contractures. In contrast to past class discussions, there is limited evidence that found slings to be effective with repositioning and supporting the glenohumeral joint when a sublux is occurring. Of course, arm trays and troughs could also be used to support the joint. One of the first signs of ALS is a condition called split hand. This presentation is rarely seen in any other diseases other than ALS. It is atrophy of the intrinsic hand muscles, especially the thenar area. Abductor pollicis brevis and the first dorsal interosseous muscle are usually predominantly affected, while the hypothenar muscles are spared, creating split hand, which is shown in the photo here. The black arrows show the sparing of the hypothenar muscles. This condition results in a very weak pincer grasp, and it may be beneficial to introduce the client to a thumb opponent splint. Multidisciplinary programs was another large focus of the evidence I found. These programs consist of neurology, nursing, OT, PT, speech, pulmonology, nutrition, psychology, and social work. Evidence shows that people with ALS who participate in these programs have approximately 30% longer survival than those in general care. Evidence also shows an increase in the individual's quality of life, likely due to the constant education that the patient receives. There was no difference in physical functioning or quality of life for caregivers between the two types of care. Future research ideas for this topic include finding more information on ALS itself, finding interventions that decrease levels of fatigue, and finding which specific exercise routines work, and what is considered moderate resistance. The studies I found were not specific when explaining what the participants did during each program. Because there is no known cure for ALS, the primary intervention is maintaining or improving quality of life. Because we use such a holistic approach, OTs do the best job when it comes to focusing on quality of life. Coming up with compensation strategies to allow this population to continue participating in the tasks they want to engage in is done best by an OT. If you ever come across a client with this diagnosis, it is critical to use your clinical reasoning because each client and their symptoms are so different.